So it gives me great pleasure to introduce Dr. Stewart Goldman. He's the Director of Neuro-Oncology at the Children's Hospital of Chicago, the Gus Foundation Chair of Neuro-Oncology, and the Director of the Clinical Trials Center for the Children's Memorial Research Center. His research focuses on diffuse intrinsic pontine glioma, DIPG, early clinical trials, interstitial chemotherapy, and quality of life.
I was searching for the internet. I wanted to read what was given to me as the task for this talk, and it was something in the likes of, we've polled the families they'd like to know from diagnosis through survivorship, best quality of life, things we can change, things we can't change, moving mountains, et cetera, and I thought, oh my God, this is quite a big topic, but I'm going to give you a shot at it, and I hope we can have some fun while doing this. I'm going to go somewhat rapidly, but I'm happy to stick around a little bit later. The first and most important slide is kind of where are we exactly in this big world that we're in right now. And there are things you're going to hear me say a few times, and these are things I believe with all my heart. So when I was putting this talk together, I thought, what is it that I've been doing for the last 25 years that I could express to a family that I think really makes a difference? The first thing I want to express to a family is that I don't know what you're going through. And maybe I have a very small vision of that because of what I do for a living, but the truth is, until I walk in your shoes, none of us knows what it's really like. So things you're going to hear a few times, and you're going to get to know how my own kids feel, and I call them Stewisms. And the first and most important one is that the cost of a cure has a lifetime to be repaid. I can't emphasize it enough. Every time I meet a family, every time I sit down to talk about therapies, we say this. And I don't mean financial. But everything I do to Jimmy, who's 5, Jimmy has to live with until he's 85, because what we're doing is trying to cure his therapy. And I think that if you're a team, and the physicians, the medical team should always keep that in mind. We always want to remember we are treating Tommy with medulloblastoma. We're not treating medulloblastoma. Once again, a very philosophically important point. And we want to tell to all the kids in the room, the young adults, and to all the patients that you have a tumor. You're not a sick kid. You're not a tumor. And one that I forgot to put on here that I just mentioned in our earlier moments here, statistics are really important to hear once. To know what your survival statistic is important, but that's a statistic. And after that, it's all about 1. So the numbers are either really and truly 0% or 100%, because we're talking about individuals. And I know that when I'm talking to families, they're focusing on those numbers, but don't focus ever too much. Even the things we're going to talk about late effects are just on the realm, but we're talking about individuals. Of course, there's more Stewisms. Of course, maybe the computer's not. I really believe that a team approach is going to get you better results. Second opinions are good if you want one. A physician who is offended by your request, this should be like that flashing yellow light when you're driving down the highway. I have a giant ego. I want you to go talk to other people, because they're probably going to say, even if I would do it differently, what Stu said is reasonable. It just makes me look better, and it's all about me. Let's get that straight right now. What I put in here I think is really important, if you want one. I feel like we put undue pressures on families. You know, my dad was one of those guys, if he felt comfortable with his doctor, if he felt comfortable with the plumber, that's what he needed. He didn't need a second opinion. It would have made things worse for him. So I don't want to walk out here and say, oh my God, I didn't get a second opinion, I've done wrong. No, it's about what your needs are, but you shouldn't feel that you can't get one. No question is ever dumb. Remember this at any time in your therapy. No question can be asked too often if you don't feel you have the answer. Take notes during meetings. I think this is critical. In fact, when I meet with my families, I say, let's take notes, and the next time we sit down, the first thing we're going to do is come up with the questions that happen. You know, when I go to see my doctor, as infrequently obvious by looking at me that I do, you know, I go there and she's a very nice lady and I'm sitting in a yellow gown and I'm not really very happy about being there, and she does whatever she does, and then she says, do you have any questions? And I say no, and then when I'm driving home, I have 10 questions. And the same thing happens with you guys. So write them down and ask questions later. Write your questions down. There's more. Oh my God, he's amazing. No matter what your choices you make, you have to pass the pillow test. And I have to do this too. If I go home at night and I think, geez, what was that kid's sodium? I better check it. I can't fall right asleep. That's a warning sign that I'm not comfortable with what's going on. So if you feel comfortable with the knowledge you've been given by your medical team, you can pass the pillow test. You know you're in good shape, and that may be all you need. You don't need to do research or seek 400 opinions if you're comfortable. In fact, there is a syndrome. You guys don't mind if I disrobe. There's a syndrome. You were allowed to say no. There is a syndrome out there called analysis paralysis. And sometimes, if you can call 50 of us, you're going to get 43 different opinions, and you end up doing nothing. So go to the point of comfort. Make sure you have a multidisciplinary team. Pediatric neuro-oncology is a team sport. You're going to get the best care by the involvement of neurosurgeons, pediatric oncologists, neurologists, radiation oncologists, endocrinologists, and people who don't get enough credit: speech, physical, occupational therapy, social services, school intervention, parent-to-parent programs. These are all what makes for the best quality of care from diagnosis through life. For ourselves, our brain tumor clinic is staffed by neurosurgery, oncology, neurology, social service, nurse specialists, rehabs. We have a separate brain tumor board. These are things that I think give you the best quality of care. Size matters. In fact, I'm going to show you a little bit of data. That was supposed to get a little laugh. Maybe not. Prognosis, it matters where patients are being treated. 2 studies are a little bit old, but if you looked at the Society Internationale Oncologique Pediatrica, and they looked at patients with medulloblastoma, and they looked at patients who over a certain period of time saw a high number of patients with brain medulloblastoma, those didn't, had a statistically different significance in survival. Right here from our friends in Toronto, Toronto Sick Kids is one of the biggest children's hospitals and one of the best in the entire world. And over a 10-year period, they saw 72 kids with medullo. There was other regional centers that saw smaller. The kids had the same stage, age, got the same type of radiation, and once again, there was a difference in survival. And that's really about the teams that are there functioning for you. So that doesn't mean that if you live in a small community and you want to be treated in a small community, you shouldn't, but you should at least get at least one-time input from a large center. It matters by whom. This is a leukemia study by one of my mentors, and they actually said, well, what about teenagers? Should they be treated with leukemia by adults, the CALGB, or by children's cancer group studies? And there was actually a difference in survival. Those who were treated by pediatricians and pediatric oncologists had overall better survival because we do clinical trials and because we're more aggressive. And why are we more aggressive? Because kids are healthy. They're not sick people. Participation in clinical trials, to me, is vital. I know they're not always available. And if someone in this room has a child who's not been treated in a trial, I'm not saying you got inferior care or you should feel guilty. We don't, unfortunately, are bad, don't have trials for every situation open. But you get the smarts of more than one doc, not just yours. Many times you get central reviews. I have a study that we're doing in brainstem glioma. We're doing biopsies. The second that biopsy has been taken to my lab, it's sent off to another institution for review by 3 other people. You're getting the opinions of others for free. You're getting regimented treatment. That leads to less missed tests and decreases unnecessary tests. And it avoids people like me saying, I think this is the best way to do it, because we want to know what the best way to do things are. And it gives you safety measures because they're early stopping rules. And if you look what we've done from 1990 to 2000 in clinical trials, we've taken survival rates of medulloblastoma, which were about 35 to 40%, up in general over 70%, and for certain types of medulloblastoma in the 85 percentile. And this is from participation in clinical trials. I want to give you one more example. This is a German data, the MKE89. This is a kind of slide I would show in the meeting, and what I really want to put you on here is they looked at the kids who got the same protocol, but some were on study and some were not. So the kids were treated per protocol versus those who were not on the protocol but got the same therapy, led to differences in survival. So clinical trial participation is significant and important. I also think, this is Stewism number 2427, and we will cover every one of them today. Don't accept that if it's new technology, it's automatically better. So let's talk about a little elephant in the room, proton beam radiotherapy. And let me start by saying, I have a proton site in Chicago. I participate in the Proton Center. So you always want to be on the cutting edge, right? But sometimes you don't always need to be in it, and it's not always better for every situation. And once again, I can't even imagine what it must be like as a parent when I know everything as a parent is about keeping things in control and safe for one's children when you're faced with a diagnosis of a brain tumor, or for the patients themselves, where life is really out of control. And you want to do the best. And there's a new technology. Of course I must get that for my kid. Of course I must quit my job and move for 6 weeks to a new city. That isn't always true. And I'm saying that from the reference point of a proton beam facility physician. So let's talk about proton beams. It's all the hot topic. It's a type of particle therapy. They used to smash the atoms together and let the protons come off. Remember that from biology class, those things that used to rotate around that we didn't really like. And now we actually can spin it in a magnet so fast that the proton shoots right off, and then through magnetic fields we take it. So it's actually a particle. Due to its large atomic mass, it doesn't scatter, it stays focused, and once it hits its target, it loses its energy, what's called the Bragg peak. Well, the benefits are that it can be a referred treatment modality for big letters, capitalized, some cases, not every case. Because children are susceptible to injury from standard X-ray radiation, and their organs are growing rapidly. Treatment comparison on the left for this malignant tumor with protons. These are isodense lines, so here's 100% of the dose, maybe 80% of the dose. You can see less residual normal tissue is exposed. Why is it important? Well, let's look here. We're trying to treat the spinal cord for this medulloblastoma. There's a heat map of the dose. Why is that important? Because you can see here where the radiation has affected the marrow and the vertebral bodies, you get less normal tissue damage. And again, why is that important? Because we got all of these other important structures that I used to be able to name, but I can't anymore. I call them guts now, that are there, and we try to avoid radiation. But that doesn't mean that other technologies aren't good. Here's another case using intensity modulated radiation to a deep-seated tumor with excellent control, and this patient didn't need to travel and got just as good a therapy. So again, coming from the perspective of someone who is a proton beam team member, it's not for everyone in every case. And I hope that's the message. It's a great technology. And not every new technology do you always need, but try to still be aware and available of them. So not every kid, not every situation, limited technology, disruption of your family and your child's life, and sometimes that's just not really worth it. There's so much to be said for having friends and family and support. Many questions are still being posed if there's some actually called neutron scatter that may cause secondary cancers and other radiation necrosis. For some cases, it's the right therapy, for some not. Bottom line, discuss new therapies with your team and have a team that's open to discussing things. I gotta tell you, a lot of times people say, Stewart, did you hear about CoQ10 and Neutrinus, or whatever? And the real answer is no. And my answer is no, I haven't heard about it. Call me tomorrow, I'm gonna go read about it. And that's all you really need to hear. It's not that we need to know about everything. I learn a lot from the families. So this is a slide about my life. I have to tell you, one day I was preparing a talk, and I said with my kids, this was a few years ago, maybe we should just order out. I decided we would get some Thai food. I called up and I said, I would need lard naan, pad thai, and blah, blah, blah. And they said, what's your name? I said, Stu. She said, Stu. I said, Stu. She said, Stu. I said, Stu. She said, Stu. I went to pick it up, and I found this, and I got to tell you, a lesser man would not have eaten that food. Really, that's my life in a nutshell. And you guys thought oncologists weren't funny, is that right? I thought that. Which actually is a little sidebar. I think it's good to keep humor in your care and in your life. There's a lot of seriousness, and believe me, we take the care of the kids that we have with the most important thing in my life. That doesn't mean we shouldn't have fun and enjoy it. Let's talk about complementary and alternative therapies. You know, they're really about complementing. They're not necessarily instead of. And alternatives can just be differing than standard therapies. And they're not wrong and not necessarily bad. I think of our vincristine that many people in the room might have received. That comes from the Madagascar periwinkle bush. Somebody came and said, I have a new plant that might help cure cancer. You'd say, oh, that's a complementary medicine. But look, it's one of the main chemotherapeutic agents we use. Taxol comes from the bark of a tree. One day when my kids were little, it was show and tell day, and I thought, oh, I'm going to be so cool. I'll bring a picture of a brain. My kids are going to think I'm so hot. This is great. I'm, this brain tumor doc. And then the next lady came up, worked for the Field Museum in Chicago, our Natural History Museum. And she goes off to countries and finds new specimens of leaves and brings 3 back. 1 for the museum, one for storage, and one to send off to the NCI where they screen for medicinal compounds. I'm thinking, yeah, I'm not that cool. And then there was a fireman too, so it's like, Dad, can't you get a cool job? So again, my life. For some diseases and symptoms, I sometimes don't offer any greater proof, so we should think about alternatives. At Children's, we have an acupuncture trial, we have nutritional therapy trials. My theory is we need to study them, because if they're hooey, I need to make sure we stop having people waste time and energy. But if they're real, then shame on me if we don't implement these therapies. So be open to complement and alternative therapies, but don't let them interfere with proven therapies either. There's an interesting study that I think really is important. There was a study done. They looked at 54 patients. This was published, I need new glasses, by Dr. Pisley in Peds Blood and Cancer, and 54 patients and families, and actually 84% of the families were using some form of complementary alternative medicine. Now, some of them were just spiritual healing or dietary supplements, and the median expense anywhere from $225 a month to about $1,200 a month. But most importantly, 60% of those people said they didn't talk to their oncologist about it. There is sometimes a pervasive feeling that they're going to be really negative about this, so I'm not going to talk to them about it. And to me, that's a danger, because even if I disagree, but you want to do this, that's your right. But I need to know so I'm not doing something that interacts or causes you a problem. So be upfront with your care team, have concern for interactions, potential to wrongly attribute effects or side effects of the chemo if you're doing something that we don't know about, and work as a team. That's really on the bottom. I think it's really important to find a spokesman and an advocate in the beginning, someone to help coordinate care for your other good, screen those 5,000 casseroles that come to your door. You could bring some to your doctor, that's okay, and to give you respite when needed. I've had many families tell me that the whole community is so caring and wonderful, but they don't want to explain what they're doing next Thursday in the hospital for the 67th neighbor. And sometimes Aunt Jamie could be the person to do that for you. And I think that adds to the quality of the experience for the child and family. If you do not want to be swamped with, my cousin's brother's uncle had cancer and they did this, or I read on the internet, Okoboji, they had this new bath treatment, find somebody to screen your calls. I think also take notes, because I know that after the words, your son or daughter has blank, you don't hear much more. I don't know if anybody loves those old Peanut movies, you know, whenever Peanut cartoons, and before they go dancing, anytime there's an adult speaking, it's whoa, whoa, and I know that once I say to you, I'm sorry, the tumor did this, all you hear after that is whoa, 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 whoa. And so we know that it's important to be able to take organizational binders with you and write things down, keep copies of protocols. And I think this adds to the quality of that experience. Palliative care is sometimes almost considered a dirty word, but hospice care and palliative care are important words. They don't mean giving up. They don't mean don't be aggressive in treating my tumor, but they may mean make my life better. Because palliative care addresses the multiple physical, emotional, spiritual issues that it provided concomitant with the cancer-directed care. And it really, if you talk to our patients, and you guys know this better, fatigue, nausea, pain, vomiting, these are really important issues that sometimes we as the neuro-oncologists don't pay enough attention to. And palliative care can help us do that. And during the 26 years that I've been doing this, some of the greatest breakthroughs have been things like Insufflon catheters, or Broviax, or Portacas, or G-tubes, or Zofran, or these J-tips, you know, where you don't needleless needles, or a drug that I've been working on lately, Zerosep, a Decadron replacement. So palliative or quality care helps you during this road, and I think it can't be emphasized enough. I also believe scholastics can't be emphasized enough. Another one of my isms when I meet a kid is I say to them, all right, you have 3 weeks to milk this for every present, gift, money you can have. I want you to walk around to everybody and go, I got a brain tumor, can you give me something? But at the end of 3 weeks, if your job is to pick up the dog do and make your bed, then you pick up the you pick up the dog do and make the bed. And my message to them with humor is, I know something catastrophic has happened in your life. Let's not pretend it didn't. But you're a kid who's supposed to grow up and be a normal kid, and you want to be normal, do normal things. And that includes going to school. Now, we're not unrealistic. That doesn't mean you can just, 2 weeks from now, just be back in school full time. We need to have school reentry programs, we need school intervention programs, and we need to educate the schools. In Chicago, we're putting a program together to really try to do this. And what we found out is that we're kind of spinning our wheels. So next spring, we're going to bring all the superintendents from the Chicagoland school areas, all the suburbs, and give them a day educating them on kids with brain tumors. And maybe if we can get through to a couple superintendents, we can have a new way, as well as having individual social workers go out and talk to the school systems. So be an advocate. Bring that army out. You got to accept the things we cannot change. The experience of going into school you can change. And I don't know what they're called in Canada, but in the States it's individualized educational programs, adaptive programs. You know, I tell families, I'm sure that school principal's a nice person, but they care about 450 kids in that school. I only care about your kid in that school. You have to be out there personally advocating. And I know you had a neurocognitive talk that I can't even begin to attempt to get to that quality, and I'm sure you've heard this. This is the layman's version of it. Vocational planning, I think, is really critical for success. Our kids can be out there and be productive members of society, but I think right from early stages of the diagnosis, you have to think about where you're going next, whether that be school, training, working. Achieving the best quality of life, always keep quality of life in the forefront. Focus as a family on normal, age-appropriate activities, normal developmental behaviors, go to school, go to sleepovers, get in trouble. I always in my mind envision grandma taking the Lysol and spraying it over the entire house before the kid comes home after their first surgery, and then a child being placed in bubble wrap and taken home for the first day. And that's exactly what I don't think kids should do. You're a normal kid. We understand you're going through things, but let's keep it as normal as possible. And let's not forget that this is a family experience, because no one goes untouched from this diagnosis. You're going through this to live. You're not going through this to be alive. Keep that as your focus. Waiting, waiting, waiting. Okay, if I can't get you with fart humor, I don't know what I'm going to do. So let's talk about a few selected late effects. I'm going to leave cognitive issues out, but ones that we don't normally talk about. But first of all, what is a survivor? There are multiple definitions. Is it someone who's completed their initial treatment? Is it being 5 years beyond your diagnosis? Is it being 2 years off treatment? The NCI actually says that at the time of your diagnosis and the rest of your life, at that point, you are a survivor. And I actually like that. I like that definition. I think that's a good way to think about things. It helps you to kind of reach for quality in your life. Occurrence of the late effects can be really influenced by many things: the type of drugs, the type of radiation, the dose, treatment and frequency, the total dose, the duration of treatment, the local circumstances, post-op changes, infections, shunt issues, and your age at the time of treatment. It's estimated that about 2/3 of all childhood cancer survivors will experience a late effect from treatment. And a late effect is defined as any chronic or late occurring outcome, whether it be physical or psychosocial, that develops beyond 5 years from diagnosis. But given that, and one of my favorite things is to be in survivor clinic, or we call it late effects clinic. We actually call it STAR clinic, survivors taking action and responsibility. In our clinic, and just like here in other surveys, most people feel they're generally in pretty good health and doing well. We do a lot of quality of life research, and it's amazing the hopefulness and the positive aspects of some of the kids' lives. Childhood cancer survivors, it's estimated that in this decade, 1 in every 250 young people between the age of 15 and 45 will be a survivor of childhood cancer. What that means to me is, those of you in this room, you're not a minority. You're a big part of our country. You're a big part. Be advocates for yourself. Band together. And about half of those patients will have some developmental or other types of disabilities, and we know that CNS tumors pose additional issues. So let's go for the cure. There's a biologic cure, there's a psychological cure, and there's a social cure. And I don't think any of those three should be left out. But being more specific, what about some late effects? Well, we know there's musculoskeletal and related tissues. We know there's some cosmetic disabilities involving your bones, teeth, other soft tissues. Scoliosis, atrophy or hyperplasia, avascular necrosis, osteoporosis. I don't think we pay enough attention to these things. but it can have premature issues. Scoliosis or curvature of the spine. Look for uneven or shoulder height. Some people have back or hip pain, impaired joint functions. If you see signs of this, you need to have about every 6 month or sooner evaluation, physical therapy, and orthopedics referral. And in your late effects clinic, you should be screened for scoliosis, et cetera, especially if you've had craniospinal or other types of radiation. Osteopenia or osteoporosis, radiation, long-term steroid, low growth hormone. These are all very important issues. Risk factors are steroid use, radiation therapy, but there's things we can do now. We can get DEXA scans to see your bone strength, calcium supplementation, doing weight-bearing exercises, and of course, I'm an oncologist. No matter what it is we're talking about, we say don't smoke. Dental late effects really don't get much attention, and actually I don't know about in Canada, but in the States, getting pediatric dentists to look at medically complicated kids is an issue, especially if your insurance doesn't cover it. It is a nightmare, and we need our advocacy groups to help us with that. But we were about root thinning of the teeth, lack of enamel, and this happens especially if you were treated at a very early age with cranial radiation. So what can you do? Tell your dentist you were treated for childhood cancer, get frequent dental exams, brush, 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 floss, 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 la, la, la. Okay, admit it, they're getting better, aren't they? These are my transition slides. I've had this one for 20 years. I love this slide. Okay. The eye, complications to the eye can be affected by the location, surgery, radiation, and chemotherapy. They're very common, and you have to start looking at about a half a year off therapy through most of your lifetime. But really things like cataracts happen 2 to 3 years after radiation, and they also can be induced by steroids or radiation. It's a very simple thing to care for, but if you can imagine, if we've given challenges to children, maybe neurocognitive challenges, maybe hearing challenges, and then we don't diagnose something simple like a cataract that can be fixed, we start to make layers and layers of fixable challenges that just makes outcomes worse. Retinopathy can be a very important problem that can happen anywhere from 6 months to 5 years out. It can be due to the altered vascular supply and permeability of the blood vessels. And if you see blurred vision or wavy lines or changes in your vision, lots of spots, you need to let your physicians know, and hopefully they should be looking deep into your eyes. Optic nerve atrophy or neovascularization, very, very important. They all lead to early visual loss, so it's very important that you get ophthalmologic checkups. So see the eye doctor. Intervention and treatment exists for these problems, but only if we're looking for them. This is my life, both art and reality. You guys are a very tough audience, I gotta tell you that. Hearings affected by tumor location, chemotherapy, radiation therapy. I really wanted to be a comic, didn't want to be a doctor. This is a famous study that I think is really important, where we looked at kids who got full-dose cranial radiation, kids who got cisplatin, and the kids who got a combination of them. And you can see it's not just to blame the radiation or the chemotherapy. In group 1, group 1 received cisplatin, group 2 got radiation, and when we use it concomitantly, we see a fall off in hearing. Now, these audiograms are really important, and hearing, I think, is one of the most important issues that we need to pay the most attention to. And I like this piece of paper. I give this to my patients because that graph I just showed you doesn't mean much, but this does. This is like being next to a piano. This is like a jet taking over your head. And this area where we see the loss is where those kind of sounds that your teacher is saying in front of the classroom can get confused. And so if we don't pay enough attention to our hearing, we may give ourselves more academic challenges. But there are interventions. You can get frequent audiologic exams. There are ways of modifying the chemotherapy. In fact, downstairs we were talking about for some medullosa, we really continue to increase the cisplatin even more because we're seeing survival's the same, less hearing loss, amplifications, and things like cochlear implants, new hearing aids, and now we are using protectants for hearing with cisplatin. So there is a cusp of change going on, and there are ways that we can avoid some of these side effects. One day a week I allow myself to eat anything I want. The rest of the week I still eat anything I want, but it's not allowed. This one really is true to life. Okay, and let's talk about some endocrine side effects. Well, one of the first ones, and I think I probably need to speed up a little bit, or am I doing okay? Speed up? Okay. Next slide. When we look about radiation effects can be either from scatter from the radiation, they can be from the pituitary axis, but we know that craniospinal irradiation can increase the thyroid stimulating hormone. That in itself can lead to thyroid cancer later. So you'll see some children are on thyroid replacements even when their thyroid levels are normal. We know we look for things like fatigue or cold intolerance, growth, constipation, muscle weakness, puffy face. Routine evaluation is critical. Growth is a very important issue. I'm going to speed up a little bit, but I do like this one. The older you are when you get spinal radiation, we're just talking about the vertebral bodies now, the chest height, which is about 50% of your height, you lose less of that by vertebral growth the older you are when you're radiated. And that's a very important feature. But this one's even more important, that we know after you've had craniospinal radiation, within 1 year you fall off the growth curve because you become growth hormone deficient. And what's really important, I wish that the growth hormone was called G7461, because when we want to give growth hormone, that would scare me as a parent. You want to give growth hormone to somebody who just had a tumor? You want to make something grow? And that's really not a worry. And I'll talk to you about, I'll skip this one, growth hormone therapy. It's very important because it increases the height of the bones that are capable of growing. You can't wait too long. If your growth plates fuse, as happened to us in our teenage years, you can give all the growth hormone in the world, it's not going to make you taller. Anybody who has scoliosis, whether they're getting growth hormone therapy or not, that goes through a rapid growth phase is a concern of their scoliosis change. But knowing that is 95% of making sure you've taken care of it, right? So it's if you didn't know they're connected, there's a problem. So getting back to this, the study that I published, was a member of the publication, 11 biggest brain tumor programs in North America, 10 in the US and Toronto, sick kids. We looked at kids who were with medulla who were off therapy at least 5 years. They were all treated when they were younger, and we looked at those who got growth hormone and those who didn't, and there was no difference in relapse or progression or secondary cancers. An even bigger national cooperative group hormone project from 1985 to 1995 looked at 19,000 patients. If you add up, if you get it for 8 years, your count is 8 patient years, 47,000 patient years, 12,662 brain tumor patients included. There was no increased risk of recurrence, leukemia, or secondary tumors. So this is safe therapy to use and makes a giant difference psychosocially, emotionally, and physically. This is the Genome Project. I didn't think that one was going to work either. But I was told that this is going to be on the web, and I had ones that were more like the fart jokes, and I didn't think that was appropriate. We should talk a little bit about fertility and risk for infertility. Some cancer treatments put patients at risk for delayed puberty and infertility into adulthoods. Some patients may also be at risk for early menopause after cancer. Various factors influence fertility after treatment. Your age, your gender, the type of treatment you have. We know certain agents like high-dose cyclophosphamide, procarbazine, radiation to the brain and spine and to the pelvic region will lead to infertility. Infertility is never really an issue when I meet people at diagnosis, but a day later it may be, and it might be an issue for the patients. So there are some things we can do. Still, the gold standard is sperm banking. It's usually about 13 years of age when we can do this. Sperm has been frozen for more than 20 years with successful pregnancies. Research suggests better outcome if parents do not accompany the patient to the... I would have to say, for an adult, having your kid go along may affect that too. So we do have preservation options for females, embryo freezing, though you still need a sperm ultimately to fertilize the egg. Hormone stimulation may be necessary, but it is doable. Invasive procedures, egg freezing. At our institution, we have an oncofertility program, and there are experimental options now for prepubertal girls to have one of their ovaries frozen to be used, and successful pregnancies have been obtained. Use of hormone, such as gonadotropin-releasing hormone, agonists, antagonists, protect the ovaries have also been looked at. So the bottom line is here, the conversation regarding fertility should take place before, during, and even after treatment, because there are new options, and as these issues become important, They're important to us as well in this whole process. But like growth hormone, then there's questions that come up. There are familial cancer syndromes, but that is the vast, 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 vast minority of patients with brain tumors. Large studies in ALL and smaller studies in people with brain tumors have shown that your offspring have no increase in congenital malformations or other diseases. Getting pregnant while getting chemotherapy is a different story. But if you're not pregnant, if you're not taking chemotherapy or radiation for 6 months or longer, you have no increased risk. So that's an important thing for survivors to hear. So what to do? We have lots and lots of options. And I've started to put a few things like Fertile Hope, which is a part of the Lance Armstrong Foundation, or the American Society of Reproductive Medicine. All can give you more information on this as you go on this journey. Now, this is my favorite joke slide ever. I'll just wait for the laughs. Oh, come on, okay. Maybe that's toilet paper, that's Kleenex. Come on, that's funny, guys. Holy samole. Of course, the therapies we do also have direct toxicity to the central nervous system. It can be from the radiation, the chemotherapy, the tumor itself, or the surgery. Things like leukoencephalopathy usually happens with intrathecal methotrexate or IT methotrexate can present as unsteady gait, little focal deficits, dementia, or even areas of necrosis leading to neurologic toxicity. And we know that especially from radiation, cerebrovascular disease is very important. It's seen anywhere from 2 to 20 years post-therapy, about 5 years out, where people can start to get acceleration of ordinary atherosclerosis. So it's very important that our patients watch their cholesterol and triglycerides. Now, of course, me saying that probably isn't very meaningful since I just ate a jelly donut walking here, but it is very important for our patient population, and any signs of a TIA or a stroke have to really be taken seriously. In fact, we know that brain tumor survivors do have an increased risk of stroke. In fact, patients who've had cranial radiation over 30 years definitely have an increase compared to the rest of the population of stroke, and something you need to watch for carefully. And one of my areas of research, as I mentioned earlier, is quality of life, and we're very interested in studying fatigue. If you look at adults with cancer, 15% of 5-year adult cancer survivors still complain of fatigue as an issue. And it's not one that we talk about. And we know that the patient is cured when he can again do the things he loves to do best. For many, tiredness is a long-lasting effect that really can make some of these things elusive. This unwelcome, unexpected late effect can cause physical, mental, emotional, scholastic, and even financial distress. But I've been in the survivors clinic where we've talked about this, and I've had patients say to me, "Oh my God, I just feel better knowing that that's not just me, that this is really a syndrome." And it's just not the being awareness. There's things we can do. And the causes can be anywhere: ongoing anemia, poor nutrition, sleep disturbances, obesity, low thyroid, long list. But weariness, low energy after sleep, prolonged exhaustion after exercise, decreased ability to work, decreased attention span, difficulty concentration, confused thinking, short-term memory problems. So again, when I think about making sure that you get the best quality of life, it's about all these little things that can add up to really being an effect if you don't look at each individual organ system and say, how can we make sure it's not interfering? Signs and symptoms can be decreased sexual desire, feelings of sadness, frustration, or irritability. So what can we do? We can do counseling and medications for depression. You can do increased fluids for hydration, nutritional counseling. You can do physical therapy. Oops, I have to go back, sorry. Oh, that one you liked when I wasn't even trying to do it. Let me make sure I'm there. So what are some of the real things that we suggest? Experiment with activity and rest patterns. Be realistic. Engage in reasonable exercise. I think it's sometimes patients say, or like me going on a diet, well, tomorrow I'm going to eat nothing and I'm going to work out for 2 hours. That lasts about a day. Make a reasonable approach. Schedule activities when you have the most energy. Avoid stressful situations. Find activities to refresh your mind, walking, gardening, painting, cooking. Focus on what you can do, not what you can't do. And then try to make it a little bit more each day. Okay, it can last a second time because this is being recorded. Secondary malignancies are really an issue as well. Radiation and chemotherapy both contribute to this risk. It speaks for long-term surveillance once again. Many radiation-induced secondary tumors and Kids who've had cranial radiation can be either meningiomas or GBMs. Chemotherapy can lead to some malignancies. And this is the 9961, a national trial for kids with medulloblastoma. And actually, what we're seeing now, these little late peaks, are really secondary malignancies, not medulloblastoma coming back. Toronto sick kids, once again, I tried to keep this local, did a big study of 211 kids, and they had 8 secondary malignancy in 7 kids, 3 leukemias, and the 20-year cumulative rate is actually pretty high, about 10%. Some of these, though, are, dumb doctor number 7 thing to say. Some of these are pretty easy, mild cancers, right? That's a stupid thing to say. But basal cell carcinoma, they are usually non-invasive. But secondary malignancies are there. Psychosocial effects. There is a post-traumatic stress disorder. I think that this is a life-altering event for the whole family. You've been through painful procedures. When a child is diagnosed with cancer, everyone in the family needs help, including the shadow survivors, the siblings, the rest of the family. And studies have been done. Almost half the siblings experience post-traumatic stress disorder as well. And so we need lots of social, and we should never let the parents, the siblings, the family, everyone else out of this experience. And one thing that I worry about is cancer discrimination. I really believe this is real as we try to work our way through the future. Studies with Hodgkin survivors that 20 to 45% have reported job discrimination in hiring and benefits. Blue-collar respondents face greater levels, 84 versus 54%. That's an ACS report. Childhood cancer survivors compared with siblings, 80% versus 18 rejection from the military, 32 versus 13. Now, some people may say that's good. Rejection from non-military jobs. This is old data. But I think the important thing is we have to really be advocating for our families and ourselves. Job discrimination should not be allowed. There are some resources here. I just saw that Dennis has come in. We have international resources as well as users research. This is just a small list. Department of Education, Clearinghouse on Disability Information, job accommodation networks. We have to focus on these things. So what the survivor can do to maintain health, exercise regularly, get enough sleep, eat a well-balanced diet, drink alcohol in moderation, except occasionally, no smoking, and wear sunscreen. And don't smoke your sunscreen. And some more resources, and these are just a few. I could have gone forever, but ones that I find are very, very helpful. Things like the American Brain Tumor Association. And again, this is not a preferred or exclusive list. I'm sorry I didn't put everyone who's here already. The PPTF, the NBT, the CBTF, Brainwaves, Gilda's Club, many, many that are on here, but they're out there for you. And I think what you're doing today is really a tremendous resource, and I think the families at Toronto Sick Kids should be applauding themselves for putting this together. There are long-term follow-up guidelines now for survivors that I think are important, and one of the nice things now is there is this interactive passport to care, which is great for physicians and give to families, looking at what you've had, what evaluations you need, what frequency, and what your risks are. So what's the future? Multidisciplinary teams are focusing on survivors and their issues. Quality of life assessments are now written into new studies. New therapies are designed to minimize late effects. And presently, psychosocial research has shown survivors' worries and anxieties are no greater than age-matched controls and actually less focused on their health. One of the first studies I did with a psychosocial scientist at the University of Michigan who helped start Candlelighters, we looked at anxiety among cancer survivors, and it appeared that our survivors were actually less anxious than age-matched controls. Now, when it came to specific subtypes about health and health-related issues, those anxiety levels, but it seemed to me like, oh, this is obvious. These people know what there is to worry about, and the rest rolls off their back. And despite the myriad of late effects we've talked about, these children and young adults must face the majority. The majority who are polled are satisfied and happy with their lives. And I think that they have a bright future. So be involved, ask questions. That changed the font when I loaded. I was not making a plea for my people there. I certainly hope the next slide has crucifix as the bullet point. I didn't do that on purpose, I swear to God. That was an unplanned slide, and I got more laughs than everything else. Be involved, ask questions, seek multidisciplinary care, but make sure there's a quarterback to your team. For many of my patients, I feel that I'm the quarterback, the traffic cop, the crossing guard. I need to have all these people involved, and it's my job to make sure you're getting those services. Make sure there's new treatments that are aimed not only at survival, but to minimize late effects. Your child is a child and needs to be treated like all other children. Remember that. Evaluation and early intervention are the key to avoiding some of these late effects. And despite all the challenges, research shows patients are satisfied and happy with their life. I have to tell you, one of the greatest joys of my life is the survivors I meet. These are special people. They are adding to this world in a very special way. So remember, for those patients in the room, you are a person who had cancer. You are not a cancer patient. And one of my last duisms is never settle for where we are. Have pride in your accomplishments, but have passion to change the future. And together, I think we can do that. Thank you very much.